Hey everyone, my name is Zachary Dingus. Go by Zach. This is my presentation on opioids and the epidemic as it relates to West Virginia. So, what are opiates? Opiates are a class of drugs that are naturally found in the opium poppy plant, and they work in the brain to produce a variety of effects. Types of opioids can range from morphine, hydrocodone, oxymorphone, and codeine to heroin, which is even used recreationally without a prescription, of course. When opioid medications travel through your blood and attach to opioid receptors in your brain cells, the cells release signals that muffle your perception of pain and boost your feelings of pleasure. Opiates have been around for hundreds of years and can produce a high and euphoric feeling in users. Opioids can be made from poppy plant, for example, morphine, which is used medicinally, or they can be synthesized in a laboratory, such as fentanyl. The history of the abuse of opiates. So, opiates have been used and abused for hundreds of years. Heroin became available over the counter actually in America in the early 1900s. It was even available in countries in Europe before that. Opioid pills became readily available in the 1990s. There was a flooding in the Appalachian region due to a combination of excess prescriptions and patients who said they had chronic pain. The usage rates climbed, and the death rate attributed to opioids continue to climb. More than 500,000 in the United States are dependent on heroin, and an estimated 10 million United States citizens are addicted to some form of opiate. In 2017, the HHS acknowledged the severity and declared the opioid usage is a public health crisis. So, a little bit of statistics about opiates and their use in the United States. Nearly 5 million U.S. residents use an opioid medication. That can be a medication that is prescribed to them, prescribed to a loved one, but they use that medication. Out of 760,000 drug overdoses since 1999, two-thirds have been from opiates. So that is a pretty staggering statistic. It is estimated over 10 million U.S. residents abused an opiate this past year. Only 1 million U.S. residents receive medication-assisted treatment. This is anything from Suboxone to methadone to Vivitrol or the pill form naltrexone. That can help opiate patients decrease cravings, and it can even block the receptors that use opiates. 85,000 citizens died from an opiate overdose in 2020. To put these numbers in perspective, West Virginia has 1.6 million residents. Nearly 100,000 residents would meet criteria to be diagnosed for opiate use disorder. In 2020 alone, nearly 2,000 residents overdosed and died on opiates. So, what are the risk factors that are associated with using opiates, and who is vulnerable to be addicted to opiates? So, risk factors when you are, using opiates or to become addicted to opiates include people who have chronic pain, who are in poverty areas, who are unemployed, have a family history of substance abuse or substance abuse disorders, and someone who has regular contact with other drug users. So, vulnerable populations would include the homeless, mentally ill, and people who live in rural areas. So, as we can see, due to the risk factors and the vulnerable populations for opiate use disorder, West Virginians seem to check many of the boxes for the risk factors, and many become or are a part of a vulnerable population. With so many boxes checked, it becomes apparent how this region became the center of the opioid epidemic and continues to struggle with the addiction of opiates. So, what are the short-term side effects of opiate use? Some common side effects that are seen in opiate users would include small pupils, weight loss, lethargy, changes in appetite, isolation from friends or family members, slowed breathing, decreased respirations, dry mouth, and slurred speech. All of these symptoms would be seen with acute intoxication of opiates or when addiction begins in its earliest stage. These signs and symptoms can be reversed with the cessation of opiates. The sooner a person quits using opiates, the faster the healing process can begin and these short-term side effects begin to disappear. However, the more a person uses opiates, the more side effects they will begin to have. And with continued use, side effects can become long-term versus short-term. So, what are some of the long-term side effects of opiate use disorder? Long-term effects can range from anything between chronic constipation and other GI issues to respiratory issues such as slowed breathing or irregular breathing. You are at an increased risk of arrhythmias, increases of fracturing bones, fertility issues in men and women rise exponentially with opiate use, and you are at an increased risk of contracting HIV or possibly AIDS. So as we can see, opiates carry serious long-term side effects and can jeopardize the good health of a person with continued usage. While long-term effects can range from something as basic as chronic constipation, continued usage can lead to an increased risk of contracting HIV. The long-term effects of using opiates are becoming more clear with more research being conducted on the subject. The continued usage of opiates creates long-term effects that are serious and can be deadly if not treated promptly. So, signs and symptoms of abuse of opiates on assessment. One thing I have learned by living in the area I do is many residents are comfortable with admitting what substances they use during assessment. They are forthcoming with information such as they use hydrocodone daily or they shoot up morphine whenever they can. However, this is not always the case. As a psychiatric nurse practitioner, we need to be able to conduct a thorough assessment and recognize signs and symptoms of opiate abuse in patients. Some common signs and symptoms present in these patients can include track marks, small pupils, increased anxiety, irritability, restlessness, behavioral changes, and possible hallucinations, delusions, or paranoia. You might even see sedation of the patient or muscle spasms. It is wise to obtain a urinalysis to confirm substance abuse and rule in or out any type of substance-induced psychosis depending on the presenting signs and symptoms. So, an example of a care plan for this patient, we're going to start with pharmacological treatment. We want to get them to a detox center. So what we're going to do once they're there is we're going to administer clonidine 0.1 milligram per the opiate withdrawal protocol. Okay, we're going to utilize PRN medications such as Imodium for diarrhea, Zofran for nausea and vomiting, Tylenol for headaches, body aches, milk of magnesia for constipation, and Vistaril for increased anxiety and cravings to decrease the withdrawal symptoms. It's important to establish discharge planning with medications once that time comes, because we know that treatment with methadone or Suboxone, naltrexone, or Vivitrol is how we're going to get that patient from being discharged back home and relapsing to sustaining sobriety. Non-pharmacological treatment, as far as the care plan, would be to admit the patient to a detox unit. What we're going to do once they're there is we're going to administer the COWS, which is just the clinical opiate withdrawal scale, every 4 to 6 hours or as needed. The patient's going to have daily CBT therapy sessions. And what they're going to do is they're going to work with a case manager for discharge planning. From there, the patient can be referred to a 28-day program, to a sober living house, or they could be discharged back home. Patients who continue treatment in the 28-day program or the sober living house have shown to have an increased patient outcomes, and this should be stressed to the patient because ideally we want the best for the patient. So patient education. What we're going to do is we're going to establish a relapse prevention plan with the patient. We want them to take their medications daily as prescribed. They're never to take a higher dosage of medication than prescribed. We're going to establish a plan for what happens when they have an increase in cravings. What they need to do is recognize signs and symptoms of when they need to report back to the emergency room, to the clinic, or when to contact a provider for more information. Lastly, they need to know when and how to administer Narcan. Ideally, we would like to think our patients aren't going to relapse, or they're not going to put themselves back into a position where they're going to be around a friend or a family member who could relapse, but it does happen. So they need to be taught and know how to administer Narcan, which is can be given intranasally and in various other forms. And what this is going to do is this is going to combat the overdose, and it's going to bring someone back who overdoses on the opiates. So for referrals, what we're going to do is we're going to try, after completion of the detoxification process, to refer them to a 28-day center or a long-term rehab center or an outpatient center for addiction medicine. We want the patient to have those improved patient outcomes, and we know through the evidence-based practice and research that going on and furthering treatment is what produces those positive outcomes. So we're going to really stress that to the patient. Follow up for the will be, for the day after discharge, whether that be from a 28-day program, from the 6-day detox center, wherever they go. We're going to try to get them in and seen as fast as possible upon discharge. So in conclusion, opiate use has continued to increase in the past 30 years and finally was acknowledged in 2017 as an epidemic. The numbers of people using has continued to increase with record number high of users in 2020. It should be noted that there is help and treatment to battle this addiction. Addressing these issues in the beginning phase of addiction has a higher probability of improved patient outcomes. While opiate use disorder is prevalent in the nation and the area in which I live, I hope to be a part of the solution to combating this disease upon graduation and beginning my career as a clinician.